8, 2026, thanks to Dr. Calvi. A few years back, I had been with the AP as well as IMA of Mount chapter. So, this topic that is cardiorenal syndrome. It's one of the old entity, but it's gaining momentum in our day-to-day treatment practice. As a physician, as a cardiologist, as a nephrologist, as an intensivist, then and there we are coming across the same disease. It's a giving clinical scenario. So the morbidity as well as the mortality of this CRS, cardiorenal syndrome, is more and more. Recently, a lot of innovations, innovative ideas, and new recommendations. So, few interesting drugs come and knock this area and have changed the outcome of this intake. The CRS is different from CK. CRS is cardiorenal syndrome. CK is cardio-kidney metabolic syndrome. So, cardiorenal is exhibiting the two organs. Anything one is suffering, automatically the next part will fall, this organ will fall. It's a fight between like Israel and Iran. One is a heart, another one is a kidney. Suppose in cardiac CRS, one kidney is the primary culprit. That is first 1 and 2 is the kidney, the heart is the primary culprit. CRS 3 and 4, kidney is the primary culprit. CRS fight both. It's just like a war between the Israel and Iran. The air defense system fails in tackling this issue. So automatically the affected people, the whole world is getting affected. Like that, the morbidity and mortality comes into this area. How to tackle this? So what's the relation between the heart and kidney? This man is the father of nephrology, named by Richard Price. 1830-37, he took almost 19 cases of edematous patients. He has done autopsy. And then they have found out that 3 things they have found out. One is the urine is frothy. Number 1. Number 2, in autopsy, kidneys are small. Number 3, the heart is weak. In 1837. So this is the first time he has correlated the relation between the heart and the kidney. CRS history, that is a cardiorenal syndrome. In 2000, the term this has been coined. Later on, in 2008, the first consensus definition of acute cardiac injury, how it produces AKA. In 2012, the European Society formulates a CRS classification in 2012. Now we are in a position to tackle this problem. What is the pathogenesis? And other things. So we have in a better position to tackle this situation. So it's not you, it's me. So that organ is telling it's not you, it's me. So it's whether it's a kidney and heart. CRS type 1 and 2, the primary problem is to be heart. When it is an acute heart failure due to any reasons, it affects the kidney, then it's a type 1. Type 2 is a chronic heart failure or heart pathology that affects the kidney, then it's a type 2. So reverse, 3 and 4 is primarily it is either acute kidney injury or chronic kidney disease. Secondarily, it affects the heart, then it is the type 3 and 4. And type 5 is primarily both organs having a problem, pathogenesis, and then results in the both organ failure. So why this classification is important? Because the pathogenesis, the mechanisms is different in each. So the pathways are different, mediators are different, molecules are different. So drugs which acts at those pathways, right now we are having at our hand. That's the way it is. So what's the prevalence? What's the incidence of this? CKD we know. Almost 1 in 10 adults they are having CKD. Heart failure we know that the number 1 cause of death in the world is cardiac failure. So the two entities are a non-infectious entities, metabolic disease producing these entities. Now the world is the non-metabolic diseases like diabetes and hypertension. It's almost a pandemic. India is the capital of the diabetic capital of the world, hypertensive capital of the world, slowly CKD capital of the world, CCF capital of the world. So it's like that. So almost I can say that it's a 30% disease. Almost 30% of the CKD at one point of time they are having the heart failure. Viewers, as a cardiologist, probably Calvin and other cardiologists, they have seen their cases. The primary cardiac problem they may have created around 1.4, 1.7, 2, 2.5. Many a times, 30% of the cases. So this is where this entity comes. You know, normal creatinine value is 1.2, am I right? But creatinine is a late marker of renal dysfunction. Anyone is having a rise in serum creatinine more than 1.2, that means 50% of the nephrons already lost its function, either temporarily or permanently. Anybody's creatinine is 1.4, that means 50% of the nephron has lost its function, either temporarily or permanently. Suppose the serum creatinine is 2, that means what? Anybody's creatinine is more than 2. So how many percentage of nephrons lost its function? 78% of the nephrons lost its function. So creatinine, whatever they are doing in the clinical practice, is a late marker of renal failure, renal dysfunction. So this is the problem of this intake. It's a very much vulnerable subset of population. This is both for morbidity as well as mortality. Number one. Number two, this CRS population is having a very limited clinical studies. Throughout the world, you take either from any corner, intensivist corner or cardiologist or from a nephrologist, we have a very limited clinical evidences of the drug, whether it acts or not, very limited evidences. So how to approach this problem? So any patient with a heart failure patient may get hospitalized or rehospitalized. Okay. So then the acute decompensated heart failure, then subsequently kidneys are getting involved, and the patient may have this issue of mortality, or patient succeeded, decongestion properly done, then again patient will come. Again this cycle. It's every once in 6 months, once in a year, or once in 2 years. So quite often it's happening. This is the cycle of cardiorenal syndrome. So what is the pathogenesis of this particular entity? Any organ is getting affected. The first one is hemodynamic impairment. There is a decreased CO as well as increased CVP, increased extravascular volume, intravascular volume overload, as well as the RAS activation, and sympathetic nervous system activation, and everywhere this is a unified thesis. Okay, starting from atherosclerosis and through the diabetes, the many pathogenesis of many clinical entities. That is the final one is this one. That is unified hypothesis inflammation. Quite a number of molecules, as well as the VGF, angiotensin system improvement, everything comes into play. It's a common. This diagram will show you that this diagram heart failure occurs. So primarily we thought that when we have studied our MBBS as well as in the MD post graduation 2005 till 2005, the reason for kidney injury in acute heart failure is decreased cardiac output. Alright. But the current understanding totally changed. The primary driver is it's not a low cardiac output, it is a decreased renal filtration is due to the congestion. It is the venous pressure. That is the key driver in this situation. So why we have to understand that? So how this increased venous pressure reduces renal failure? So it's a bad luck. Just like your car is moving in the road, there is a traffic. So quite a number of vehicles are standing one after another, and it's a bad luck. Like that, there is a venous congestion, and there is increased CVP, central venous pressure, automatically it's getting into the capillaries of the nephron, the functional unit of the kidneys, and then slowly the tubular pressure, glomerular pressure increases, and then so slowly it's getting into the, and it's not the glomerulus. both tubules as well as the glomerulus, that reduces the CNF function. So this is the basic pathology. So understanding this one, why it is important. So the increased central venous pressure directly impairs the glomerular filtration rate by reducing the transglomerular pressure gradient, acting as an independent predictor of mortality. This has been proven now. This is the latest understanding, recent insight as far as the cardiorenal syndrome is concerned. So clinically, how do we know that is central venous pressure? We know it is more than 8. If it is around 10, then it is significant in this clinical setting. Like that, IAP, that is, if it is more than 12 millimeter, it's recognized as a primary villain, primary driver of this clinical event. So, the management so far, there are two pillars. One is that is decongestion, as far as the CRS1 is concerned. Okay, number 2 is next one, that is the GDMT, guideline mediated medical therapy. What is GDMT? It is ABC. A for either AC inhibitor or ARB, number 1. B for beta blocker. C for put it as C for S, CAP inhibitors. D for aldosterone antagonists. Okay, these are the 4 pillars of the this guideline directed medical therapy, GDMT and so on. These are the 2 pillars. One is decongestive therapy, another one is GDMT. Coming to the decongestion, first before starting the decongestion, first ensure the hemodynamic optimization, ensure the adequate blood pressure and cardiac output, use vasodilators, and if necessary, you can go for inotrops. And diuretic therapy, you know what we are doing, that is furosemide and torsemide we are using, intravenous dose, whether it has to be used as intravenous or oral. In acute clinical settings, automatically intravenous. And then the next question is whether it's a bolus or infusion. Next one, whether it is a torsemide or furosemide. So these are the questions I will explain one after another. So avoid nephrotoxins and monitor good serum creatinine and other things. Skipping. So the goal is to relieve the condition at the same time minimizing the renal issues. How to relieve the condition? The first one is the low diuretics. That's the golden one. Every people we are doing that. And SGLT2 inhibitors, to some certain extent it helps. And then nitroglycerin. So condition with the volume overload, loop diuretic. This drug starting dose is around 20 to 40. Or intravenously you can use. Already patient is on 20 to 40 milligram of furosemide as a OP outpatient. Then you have to double the dose in the intravenous. So you have to repeat it once an hour. You have to evaluate the response. You are giving the furosemide. Then what the recommendation says, after 2 hours, you do a urine sodium analysis. Okay. It is significant. Then your drugs is working. There is no need to increase the dose. Or you have to go for a urine output. Clinically, if it is after 6 hours, then you have to assess the urine output. If it is around 0.5 ml, for example, 60 milligram, 60 kg individual adult, then you have to expect around 30 to 40 ml per hour. That is 0.5 ml per kg per hour. So patient after 6 hours, it should be around 40 ml per hour into 6 hours. It should be around 200 to 250 ml. So that means the patient is responding to your diuretic Lasix or furosemide. So if this one, if it is not no response, you have to double the IV loop diuretics and assess within the 6 hours. The urine sodium, what it means, if it is less than 50 to 70 milliequivalents per liter, then it is not responding. The diuretic is not working. Right there, the less than 100 ml per hour, the diuresis is not occurring, then the drug is not working. So strategies, at the time of strategies, we will condition without worsening the renal function, IV loop diuretics, monitor the output, adjust the dose, and if it is not there, next you have to go for the second, the diuretic, thiazide or alpha preparation. Then daily you have to monitor for daily weight, JVP, edema, blood sound, renal function, electrolytes, hemodynamics. So this is what it has to be done. So which one is better, furosemide or torsemide? Any takers? in the clinical experience. Furosemide, as far as intravenous is concerned, mostly we are using furosemide. Dorsomide is not much available, but the clinical evidence says that there is no difference between the dorsomide and furosemide. Even though dorsomide, the half-life is more and its availability, oral availability is better, but as far as acute setting is concerned, it's intravenous furosemide. As an outpatient, you are discharging the patient on the 7th day or 10th day, then automatically the dorsomide is better than furosemide. So there is no difference. See the primary outcome, the all-cause mortality, there is no difference between the dorsomide or furosemide. Dose equivalence may be 1:2 or 1:4. So depends upon the situation it is like. There are some reasons where you have to increase the dosage of either of this molecule. Depends upon the situation. Patients with the liver disease, patient along with the renal failure, then in such situations you have to increase the dosage of this. So this is the thing that is above the conversion already told, that is 1:4 or 1:2. Just I am skipping few things here slides. So bolus or infusion. So many times in my clinical experience, my own experience, most of the time I'm going for a infusion. That is either by pump or by the hourly impulses I'm giving. For example, 40 milligram I'm taking, or 60 or 80 milligram. For example, 4 cc of glasses plus 6 cc of normal saline. Make it as a 10 ml every hour 1 ml or 2 ml. See, my clinical practice in a small setup, I am using the such things. So I am attached to my small station, and also in Malay it is in the big station, and also in Apollo. So there is in Apollo there is no problem. Pump, it is pump. They are using pump, just 6 milligram. In my small station, one station, I am taking a 4 cc or 6 cc of lasix, adding, make it as 10 ml, just with a 10 ml syringe, and ask the system to give either 1 ml or 2 ml, and put a police catheter and every hour to measure the output, and then go for it. These are the small things, pick up the plate, you can able to do. So next one, there is no response. Diabetic resistance. Then here there is one clinical insight. Look for the chloride, that is sodium, potassium, chloride bicarb, usually electrolyte panel will have. This chloride normal value is 105, you know. If it is a hypocaloric chloremia, there is a critical marker for a diabetic resistance. This is your insight. It's another clinical bedside information. So there is a resistance. Next you go for a sequential nephron blockade. So what is it? The statins to counter this diabetic, there are many statins. The most proven is this one, that is the sequential nephron block. So we know that there are some molecules are active at this level, some are at the TAL, that is thick ascending limb, some are at the descending limb. So when you are combining 1 plus 2 plus 3, this is called sequential nephronal blockade. So one such drug is thiazide. This is a thiazide like diuretic. Okay, this acts at the level of DC. What is the mechanism? So when you are using a furosemide, dorsomide, what happens? There is this. It acts at the level of tau. That is the ascending limb. It blocks the receptor. So there is an increased secretion of the non-absorption of the sodium, and then the distal delivery of the sodium is more and more. Okay, so when the tissues are getting more amount of this sodium, so it acts more. At one point of time, it is called breaking phenomenon. So where it absorbs more amount of the DCT acts automatically. So it is intrinsic way this action reabsorbs more and more sodium and other things. If you are blocking that particular part, DCT, with the help of thiazide like diuretics, it's called sequential blockade. So it's very useful to just adding a 2.5 to 5 milligram. That's it. Then automatically you will do more amount of diuresis. So another one is MRA. MRA means it's a mineralocorticoid receptor antagonist. Still more distant. It's a potassium sparing diuretic. So you can use amyloidoid or it can be a spironolactone that you can use it. So either it can be a double or triple therapy. So breaking phenomena, you are discharging the patient with a furosemide 40 milligram or dorsomide 20 milligram. After 3 months or 6 months, patient is not responding to your diabetic dose. This is called breaking phenomena. The reason is what I have told recently. just now. So the way to counter it is, that is just use a molecule which acts at the DCT or at the collective tubule as a thiazide-like diuretic or thiazide or MRE. So other markers, NGAL and other things, here statin C is another one important molecule. It's a yearly marker than serum creatinine. Why it is not picking up in our clinical settings, I don't know. The reason probably the cost of it, the statin C is around 700,000 in some areas, and also the calibration of this statin C. So also it's a little more cumbersome. That's the reason why it's not picking up. I have done a statin C study in immediate posterior transplant settings. It's a yearly marker than a serum creatinine. So in the cardiac setting, in cardiac IC settings, statin C doing if possible. So definitely pick up yearly than a serum creatinine. So nothing works. So the aim is decongestion. So far I'm discussing about the decongestion. So still we couldn't able to open up. So what the next one is ultrafiltration. Many a times in our settings, both in Apple ICU as well as in my own another center, we have done even for a creatinine 2 with a ejection fraction 30 and other things. So ultrafiltration many a times helps to tide over the crisis. After 1 or 2 hemodialysis, we can pull out the patient from that incident and then we can give a life to them. So the ultrafiltration can be done by a machine, that is isolated ultrafiltration, we can set it, or I can take a artificial kidney outside and without giving a full one, that is a dialysis fluid, just with the help of the machine, I can remove the excess fluid alone. So virtually we can see how much fluid we can take it from the dialysis, artificial dialysis. So we can remove the fluid alone. But remember, the accuratics are not useful. Tolvaptan is not much useful as far as CRF is concerned. Why? So now so far we are discussing about furosemide, dorsemide, and then other things. But accuratics like the Ratmans, is it useful in CRS? It's not much useful because it concerns only with the water. But here the problem is sodium avidity. CRS is a state of sodium avidity. The body is having more amount of sodium. So just removing fluid is not enough. It's not a water disturbance. It's more than water, it is sodium. So that's the most important thing you have to understand. We can add, it can be add-on therapy, but it's not like it's a pillar therapy. Okay. So just I'm skipping few things. That is, if you are getting admitted hospital admission, avoid congestion, reduce congestion by various means, and you start the DDMT therapy at the 3rd day or 4th day. So coming to the second pillar, DDMT, and then you have to up titrate and send the patient. So here another clinical thing I want to say. Already told, that is angiotensin receptor, that is beta blockers, and then sodium gluconate, and then ABCD I have told you. So when to start? Your admission day is this, start with the RAS and RB. Next is beta blocker, next is MRA, the last one is inhibitor, and then you slowly titrate and then do it. It's a simultaneously, it's a rapid introduction of the one drug after another drug. So don't hesitate, don't delay the start of these 4 drugs. That's another one recent insight. And so when you are using all this drug, so it's estimated to reduce the mortality by 73% and prolong the life of a 70-year-old individual by 5 years. This is a DDMT therapy. This is the insight. So as a physician, it's a take-home message. Probably you use all these ABCD drugs in the acute CRS. So just I'm skipping the few things. So the benefits, we are using only AC inhibitors. This is the hazard ratio. When you are using ARB plus B and then RB plus B, it's like that. ACE, beta blocker, 3 drugs, it will be like that. When you are using all the 4 drugs, that will be the hazard ratios. So it completely revolutionized the therapeutic approach of the patient. Coming to the SGLT2 inhibitors, you know all the studies. There are 3 drugs of the CDE, that is canagliflozin, dapagliflozin, empagliflozin. Okay. So the canagliflozin, Credence trial, dapagliflozin, as a nephrologist telling, E for empagliflozin trial. So many trials are there, but the interesting thing about this, all these trials are, okay, all the trials have prematurely terminated. For example, study period is 2 years. All the studies are terminated in 1.5 years. 1 year. Why? Because the arm with the glyphosides are having the overwhelming clinical evidence for saving their lives. So the study group, the non-study group, they want to pass the benefit of the glyphosate to the placebo group. So this is the one area where most of the studies concerned with the SAB2 inhibitors are prematurely terminated. So just I'm skipping. Coming to this last one slide, that is a non-steroidal MRA. That's a neurocortical receptor. The latest drug included after that is spironolactone, later on eplerenone. Now we are having a fimbrinone. The cost of the drug is almost 100 rupees per day. Okay, fimbrinone is a non-steroidal. What's the advantage? Because this molecule will not getting into the nucleus. It's a non-steroid. So it activates the receptors and produces effect without producing hyperkalemia, gynecomastia. Permissive hypercreatinemia in heart failure is accepted one. So even slight rise in the creatinine in the CRS is acceptable one. You give more importance to the decongestion and then you continue the thing. So with this, the therapy has two pillars. One is decongestion, another is the GDMT therapy. So congestion, decongestion is the most important thing. Go for it. Even the permissible hypercreatinemia is acceptable. With this, I conclude my talk. Thanks for patience.
Sir, please talk on this CRS syndromes. Now we know that these two are interconnected and they are not isolated entities, and treating one will protect the other. Thank you, sir. Any question from the floor?
Please, vasopressin for patient is having a low BP in cardiorenal syndrome.
So maintaining hemodynamic stability by any means basic of managing CRS patients. From my side, using dopamine or vitamin or maintaining the hemodynamic stability is a paramount importance.
Most glomerular capillary vasopressin may increase, may improve the post glomerular vasopressin.
Even the assisted devices are available. By the help of Mani has taken something that is intra-aortic balloon pumping. So these are all again these are all the recent innovations by the cardiologists. They are changing the outcome of this CRS type of the coronary units. So that thing I have not touched because it's a review of the cardiologist.